one second.
Yes, go ahead.
Wait,
Nope.
let me introduce her.
Sorry.
All right, Teresa, we can see you and your presentation and we can hear you. So let me just do your introduction. Dr. Teresa Mattina is an associate professor of medical genetics at the University of Catania, Italy. She retired in October of 2021. And since October of 2021, she served as the medical geneticist at the Morgani Research Foundation and clinics in Catania, Italy. She has over 200 publications, 10 of which are related to 11q. And she's been studying 11q deletions and duplications since 1993 and has followed more than 40 11q patients, anywhere from ages 2 to age 30. And we're really grateful that she's able to join us virtually. She wasn't able to join us in person, but thanks to modern technology, we're able to hear from her live from Italy right now. So go ahead, Teresa.
Okay. Thank you. I started on the 28th of December, 1993, when I met my first patient. He was a newborn with Jacobsen syndrome. Since then, I have seen 238 patients with 11q problems. I have collected questionnaires for the families to collect informations and more than 30 RMI from patients. More than 40 patients have had a follow-up lasting 2 to 30 years. My goal is to support families, provide information on the diagnosis, so the genetics behind the abnormality, clinical aspects, how to address two clinical problems, and provide information on the recurrence risk within a family, checking for predisposition to break. It is essential both for me and for you to have and maintain updated both clinical information and genetics. For me, because if I want to share my information must be updated. If you want to have consultation, you need to have updated clinical information on your patient of your family, and have updated genetics as well. Jacobsen or 11q, I prefer to say 11q abnormalities, is not a single condition, but is a group of conditions. And sometimes the difference is very significant. So if you want to have information which are useful for each family, you need to have a dedicated genetic counseling for your family. And I would be happy to provide it for free, genetic counseling in person or via WhatsApp if it's not possible to meet you. Genotype-phenotype relation in patients with 11q abnormalities. I created a standardized clinical database, and keep it updated is very complicated, very difficult, but I try. Clinical aspects have been collected both on clinical evaluation, interviews with the families, and with the questionnaires. Follow-up is very important, but it's not been possible always. What's wrong? I also created a genetic database with all the information of genetics, and I try to keep it updated to have complete and updated genetic diagnosis. If I meet a new family, so I can evaluate the patients, have genetic testing, and consult my database so I can try to predict the clinical outcome and suggest personalized treatment and follow-up. there may be unusual findings. These unusual findings sometimes are bad, and some very bad symptom, or maybe good. Think of children who don't have thrombocytopenia. If a Jacobsen syndrome patient doesn't have thrombocytopenia, this is an unusual finding. It is very important to check for the presence of additional genetic or non-genetic conditions, which may help give a solution to patients who have thrombocytopenia. We may, if we know what happens when these children do not have it. And after meeting a new family, I must update my databases, both clinical and genetics, by adding this new information. Clinical findings, some are very important because they impact in an important way on the health of the patient. Organ malformation, craniosynostosis, thrombocytopenia, immunodeficiency, while others are just important for doctors who deal with rare disorders and are only nothing that can produce a problem, but gives the facial appearance of the patient or the body, difference in the body of the patients. All these clinical findings have been put in a database, and I used to code this information using the Phenomizer codes. I collected 311 clinical features from patients, almost 200 related just to the face. But why they can be useful? Phenomizer is a tool free online for doctors that can allow the diagnosis. And I send my informations together with other researchers who have studied other pathology. So I contributed to the Jacobsen syndrome that is on Phenomizer and is used to try to make the diagnosis on the ground of clinical findings. Genetics. Genetics is finding the imbalance in the patients and correctly identify the breakpoints, and then be able to check for any additional genetic or non-genetic conditions in case of unusual clinical findings, and if possible, identify if there are factors that predispose a particular family to the deletion. Genetic diagnosis in old patients was made using chromosome test. This is a test that has been performed on the microscope, and the most important equipment is the eye of the cytogeneticist that must see the broken chromosome. When chromosome test and more recent from 1991 with fish gave abnormal chromosome results, it was possible to refine these results using array CGH. But whenever chromosomes looked normal, and this could be when the break was very small, array was not performed. So some patients have escaped the diagnosis. There are patients with Jacobsen, old ones probably, that have not been diagnosed so far. To get a complete diagnosis after chromosome test, is array defines very clearly where the break is. Here you can see the deletion, where the deletion is. And the identification of loss or gain when there is a gain is very clear. And sometimes you see both gain and loss in the same or in different chromosomes. So you can identify complex unbalances that could not be seen by the use of chromosome test only. With array, you also, some of you that have had array done, have seen that there are VUS, variant of unknown significant. These are very small unbalances that you cannot say if they do any damage to the patient. They are to taken into, they are not a good result when it's a prenatal diagnosis because you don't know if they're meaning. And array is always unable to detect the balanced translocation, balanced anomaly. So in new patients now, array is performed straight away, and all unbalanced, all unbalances will be detected. And so more recently, my patients have both deletion and duplication on chromosome 11. You can see 2-1 in this slide. There is a deletion and a duplication, deletion and duplication. And if you see the chromosomes, they look normal because there is a loss, but there is a gain. And even if you do fish would stain as normal chromosomes. So these have been detected just by array. New patients, array is performed straight away. All unbalance will be detected, but we miss any balance rearrangement, including parental. If one parent has a balanced translocation, we cannot see it by array. We miss the structure of the rearrangement, and we may miss some mosaic cases. So some diagnostic error are possible even with this more advanced technique. You see, this is a cell, and you see these are chromosomes. And there is a chromosome that has been stained green, and another one is red. But these two chromosomes, the couple, the second chromosome, the second green chromosome is broken in 3 pieces, and the second red chromosome is broken in 2 pieces. You can see by fish. But on array, this would be normal because there is balanced. But we don't know if there is any damage with these translocations. There may be VUS, small deletions that are considered meaningless variant. And then the lab may not even report VUS. But balanced abnormality may have also give problem with positional effect, because there are some genes that need to stay separate, and then here may be close, abnormally close one to the other. And some genes might need to stay close, and instead with the translocation, they have been separated. Now, I show you some cases of my, among my patients. Array is more precise than karyotype, but let's see the first. The first case is a patient with deletion, wide deletion, which turned normal on array. My suggestion, I'm sure this is a mosaic, and this means that there are cells with the deletion that could be seen on the microscope, the chromosome test, but array did not see the deleted cells. So there are cells with and cells without the deletion. This is even more interesting because on chromosome, it was a normal 46X and a large, very large duplication of 11q, and the normal cells were 18 and 66 were duplicated. While doing array, turned out a deletion, a small deletion. It is, again, a non-detected mosaic. Well, the chromosome test has missed the small deletion, while the array suggests has missed the duplication. And in this case, there is a mosaic normal deletion. For array, there is only deletion. This is a mosaic. And this is a straightforward deletion. It's a terminal deletion correctly mapped by array, but in array, they showed also VUS. Very small duplication, 6, very small duplication of 7, very small deletion of X. Is there any relation with the unusual clinical finding that this patient has got? Any test may miss mosaicism. Mosaic is a person who has normal cells, here is white, and cells with the deletion is the blue spots. But mosaic could be also a mixture of abnormal cells. Red are the duplicated cell with the duplicated chromosome 11, and the blue spots are cells with the deleted chromosome 11. And any test may detect both or only one cell type. This was the result with chromosome test. This was the result with the chromosome test. It missed the deleted chromosomes, but saw the duplicated. And this is the result with the array. Saw the deleted, the terminal deletion, very small, that cannot be seen on chromosomes, but was unable to see the duplicated. How do they look if they are mosaic? They may be Jacobsen, straightforward. They may look mild. They may look even normal. A parent of a Jacobsen patient could be a Jacobsen patient in mosaic and be perfectly normal. And if we detect mosaicism in prenatal diagnosis, it must be clear that the percentage of abnormal cells that are reported on the laboratory report is not reliable. When there is a mosaic, you may see a normal patient with a lot of abnormal cell in the report, and you may see an affected patient with, in the report, show very few abnormal cells. So what is Jacobsen? It's a partial chromosome deletion, and is causing a syndrome that involves all the body. Is a contiguous gene syndrome. This means is a missing or additional fragment of chromosome containing a number of genes that are contiguous. They are close one to the other. The picture of any contiguous gene syndrome is 4 characteristic. Dysmorphic features, the appearance of these children look alike if they have the same contiguous gene syndrome. Intellectual disability, physical developmental abnormality, and organ malformation. These four are always present in variable severity. And the severity is in part related to the size of the deletion. The wider, the more severe. To get a complete diagnosis, we need a traditional karyotype with fish. And with the traditional karyotype, we have bands. Q23.3 is one band where the deletion can be, but this is a wide band. Only with array you can define where the break is. Predisposing factor, balanced translocation in one parent, mosaicism, or fragile site. Parental analysis cannot be done by array, must be done by fish and chromosome test and fish that can detect balanced translocation, while array will be a normal. We should check for mosaicism or test for fragile site, but these tests are very difficult and very few labs would do that. So the best thing is to offer prenatal diagnosis in case of a second pregnancy. To get a complete diagnosis, then we have chromosome analysis, array CGH, or SNP array. SNP array is another kind of array where you can see whose chromosome is the broken one, if it's paternal or maternal. And then you can go with other techniques. Jacobsen is a chromosome genomic disorder, is a contiguous gene syndrome, multiple congenital malformation and retardation. It's due to chromosome imbalance involving a specific chromosome region. It's not a gene disorder. It's not a single gene disorder. It's not a collection of a number of single gene disorder. Jacobsen syndrome, we have missing one copy of a piece of chromosome 11. There are many genes. There are 346 genes in the wide deletions, but don't worry about most of these genes because there is only one or two that ETS1 and FLI1 that give straightforward symptoms. The other ones contribute in a partial, very mild way. Otherwise, if all these genes would give a problem, there would be a number of syndromes together with Jacobsen. Why is that? Because besides the broken chromosome, there is a complete healthy one. And this could be enough to save from these pathologies. So we have missing one copy of a chromosome region, but how are the genes on the non-deleted chromosome? So we may have a severe phenotype if on the other chromosome there is a mutation. The breakpoints on chromosome 11 are wide or small. The deletion may be wide or small. These are my first 50 patients. And you can see here, this patient had interstitial deletion, but had Jacobsen syndrome. So maybe this little bit of chromosome 11 that was saved from the bottom of the chromosome was not influential. And I must say yes, because this patient had a deletion of just that region and didn't have Jacobsen syndrome. This is a patient that has the smallest deletion with the Jacobsen syndrome. So Jacobsen syndrome is here, and patients who have deletions on other region do not have the same phenotype. Patients who have wide deletions have more complicated phenotype, Patients who have smaller deletion have partial Jacobsen syndrome. It can be a terminal deletion or interstitial deletion. Expression is variable, depends on the region, on the size, genes involved, if it's mosaic or non-mosaic, if there is any additional imbalance, and positional effect. But for patients who have the same conditions, genetic compound of non-deleted chromosome and other chromosomes influence the phenotype, and also the environment. Epigenetics, that is the way how cells switches on or off genes. So it is a contiguous gene syndrome. It's not a collection of single gene disorders, and both parents contribute to the phenotype. Don't blame the parent who has given the broken chromosome, because both contribute to the phenotype. There are cases of complex imbalances. Deletion of chromosome 11 with partial duplication of another chromosome region, any chromosome in unbalanced translocation. There may be deletion of chromosome 11q and duplication of chromosome 11q, as I'm seeing more often in these days. And there is another condition, a deletion of chromosome 11q with a duplication of chromosome 11p. In this case, we can have the phenotype of Jacobsen, or we can have instead the phenotype of the duplication, or we can have a complicated condition where both the abnormality work. And the same here, you can have a deletion with a duplication 11q. The phenotype could be just deletion, just duplication, or both. And 11q deletion, 11p duplication, there is a difference, because if duplication is maternal or paternal, the patient has a different syndrome, because chromosome 11, maternal and paternal, in the short arm behave in a different way. So the clinical syndrome must take into account all these complications. So any results on genetics needs a critical evaluation of the phenotype, and the technical analysis must be updated. Why we need a precise diagnosis? Because we can better care and identify factors that predispose to recurrence, may help decision-making process, and may make it possible to identify other patients in the family. Family history is usually, Jacobsen is usually sporadic, recurrence is very rare, but the prenatal diagnosis should be always available, because it's not possible to distinguish very well if family is at high risk, one parent is carrying a balanced translocation or mosaicism, or Jacobsen, or straightforward Jacobsen, or a low risk de novo. Both parents have normal karyotype, because some parents show normal karyotypes, but one is an undetected mosaic Jacobsen, or has a fragile site, or has a rescue of monosomy, that are conditions that predispose with high risk of recurrence. If we study family recurrence risk, in this family we have a father and mother that are normal and an only child with Jacobsen. The recurrent risk is hypothetically 1%, hypothetically. But if we know more of the family and there is no other case in the family, nothing more, this hypothesis is stronger. While if in the family there are miscarriages, I would be very careful, because miscarriages could be patients with the same condition that have been aborted, miscarried. And recurrence risk, when there is a family with two cases like that, sister of the mother and the son, the mother is carrier for sure, or the same if it is the father. And if normal parents with none in the family, they have two children with Jacobsen, of course, one of the two parents must have or a balanced rearrangement, a mosaic, fragile site, and other relatives may be at risk, including siblings of the patient. Recurrent risk when there is one parent with a balanced translocation. Here we see a balanced translocation, chromosome 11, and this is another chromosome, and this is the other chromosome with a piece of chromosome 11. If the parent gives to the son the offspring always the Jacobsen, you can have two Jacobsen or more Jacobsen in the same family, but the parent could give the other chromosome. So in one family, we could have two different chromosomal syndromes. Fragile site. I have found the fragile site in the mother of this. This is one of my very first patients, and the mother of these three children with mosaic chromosome 11 deletion. We have published this paper showing the fragile site. And there are papers publishing about fragile site, but unfortunately they have studied chromosomes, not molecular test. Chromosomes in my patients were normal. The only molecular tests showed an increase of the region that causes fragile site. So fragile site is surely underreported. What if a parent has a balanced translocation? If it's a father, there is a reduced fertility because some sperms might be affected and some are not. And the ones that are not affected are quicker to join the egg and fertilize. While if the mother is carrier of the balanced translocation, the recurrence, the risk is higher because the mother only has an egg each month, and this could be normal or not. In my cases, 2/3 of pregnancies have been normal, 1/3 have had reduced growth, intrauterine growth, abortion threats, preterm labor, abnormality of placenta, polyamnios, maternal high pressure. And in prenatal diagnosis, the scan is normal in most cases. There can be the possibility to see reduced growth, heart malformation, kidney malformation. Reduced growth could be mistaken for abnormal weak count. The pregnancy is considered to be not taken normally. Test is normal in most cases. The way to do prenatal diagnosis is by NIPT, amniocentesis or CVS, but with array that allows the detection of most deletions. But of course, if they detect a VUS, there is a question mark on the results. The baby at birth is small baby, dysmorphic face, frequent heart malformation, bleeding, pyloric stenosis, feeding problems, pulmonary problems. And at any age we have the diagnosis, there must be a checkup, including all the specialists, because all the body must be checked. There must be, in Italy, we have the clinical geneticist is selects the specialist to send the patient. A clinical finding, the pediatrician would look for physical development, malformations, swallowing difficulty, vomiting, constipation, because it's very important to know if it's functional or needs operation. Hematologist, immunologist would see low platelets, sometimes low blood, white blood cells, anemia, low immuno cells. A cardiologist for cardiac malformation, but also the vascular specialist for other vascular problems. The neurologist, developmental delay, mental disability, autism, brain malformation, seizures. And endocrinologist, hormone may be low, ophthalmologist, because there may be ptosis, strabismus, vascular anomaly of the retina, coloboma of the iris. Otorhinolaryngologist would see narrow ear tube, ear infection, cleft palate, and deafness that could be acquired or neuro deafness. Dermatologist. And there must be done some instrumental tests, heart scan, ECG, basic MRI is suggested for every patient, and EEG, abdomen scan, and X-ray when necessary. Complete blood test is genetic assessment and all the routine tests. Follow-up must be tailored, starting from the first results. And a clinical geneticist, again, shares the patient with other specialists. MRI when required, heart scan every year, abdomen scan every 2 years or when required, X-ray when required. Abdomen scan is to check for kidney abnormality, even functional kidney abnormality that may cause infections and spoil the function of kidney. Every year, blood test or when required. And remember, there is most patients have short stature, so growth hormone must be checked. The head is, compared to the stature, is relatively large. This is the normal for Jacobsen. But there are few patients that have very small head or very large head. This need to have MRI because there may be something additional. So if you see seizures, they are unusual in Jacobsen or iris coloboma. It's likely to be additional chromosome abnormality. Pulmonary infections or ear infections, warts, there is a serious immune disorder. Very small or very large head, there may be brain malformation, very short stature, low hormones. Most children need surgeries, heart, skull, pyloric stenosis, eye, ear, and there may be complications, but most of these complications, bleeding, anesthesia, pneumonia, or other infection, can be prevented. Of course, there have been cardiac respiratory arrest. Most of them have been a good, they solved. The outcome can give good results. Relapse, sometimes the surgery of the eye, there is a relapse of ptosis or strabismus, and there may be abnormal scars with the keloids. Trigonocephaly need to be operated if the head is not growing enough. Ptosis and strabismus must be operated if the child walks with having a posture that is not normal and may cause abnormality of the spine shape. There are life-threatening pathologies, congenital malformation of the heart, or acquired. I want to stress that acquired vascular anomaly um, are important cause of sudden death, abnormal or low platelets, immune defects, and there have been 2 cases of lymphoma in severely immune depressed patient, but the prognosis was good. They go through positively lymphoma. Remember, each person is unique. Each Jacobsen is unique. Is Jacobsen because of the size of the deletion, because there may be additional abnormality. The clinical phenotype will be unique, and do not expect a real help from laboratory report or from artificial intelligence alone. You need a team of specialists and a team manager. In Italy, like me, having dealt with rare disorder, you can be a team manager for Jacobsen syndrome, even if you haven't seen, because you read the literature, you contact colleagues, and you can, a medical geneticist could be a good team manager. I would like to share with you that this is my today 50 years ago I graduated. My degree was on another syndrome like Jacobsen, but involving another chromosome, chromosome 4. I am finished.
Can we ask any questions?
I can hear very badly.
All right, I'll come up here. Can you hear me better when I'm up here?
Okay.
Can you hear me?
Not now.
Can you hear me now?
Yes.
Okay, I'm going to ask the questions from here. So you ask the question, I'll repeat it. Okay, so we're going back to the, what section? Oh, reproductive section. If a mother has Jacobsen syndrome, is
Yes.
her child more likely to be affected more severely than the mother?
I don't know how the mother is. The mother can be a Jacobsen, but she can be a mosaic Jacobsen. In this case, the child could be more affected.
Okay, so if it's mosaic.
If the mother and the child are both Jacobsen, they still may be different because of other chromosome, other additional genetics, non-genetics problems. Is clear?
Yes, thank you. All right, over here. So the question is, you mentioned about you can offer genetic counseling. How can
Yes.
we contact you?
You can give them my WhatsApp.
Okay, I have contact information.
Eh?
Oh,
You
there's a
have it.
question online. Hang on, I
Don't
gotta.
you?
Yes, I do.
Yes.
Hang on.
I will be very, very willing, but tell families that sometimes I have been contacted by a mother that gives her name and then asks for his child, giving his name, and I make confusion.
Okay.
And we must get things clear.
She's got it on hers.
All right. Any other questions in here?
Dr. Mattina, if you click the Q&A, there's a
Excuse
question.
me, Isa?
If you click the Q&A on your side, there's a question online.
Excuse me.
Oh, okay.
My son is on 98 percentile. Yes, I suggest that everybody should have a baseline MRI, especially if the head is so large.
Okay.
And it could be nothing, but could be hemorrhage, could be a malformation. How old is?
All right. All right. Any more questions here? All right. Well, thank you so much, Teresa. We appreciate it. Oh, it says he's 4.
Excuse me?
He's 4.
He's 4.
Oh, yeah.
And did he have big head from the birth? All right.
Okay. Yeah, they said, yeah. Oh, yes.
I think he must have a MRI. I would suggest.
Okay. Thank you so much, Teresa. We really appreciate you taking the time.
I'm
to
very
get on
sorry.
We miss you being here for sure. Hopefully next time.
Next time.
All right. Thank you.
Bye.
All right. Take care. Bye.
Quick 5-minute break, restroom break. We get Paul set back up.
I don't know.
Switch to the host.
How do I get out of this? I gotta figure out how to do it. Yeah. The microphone.
Where's my computer?